fluoxetine. So this is an old drug, Strattera. It was actually used for depression early on. You can see from its how it works. It's selective norepinephrine reuptake inhibitor, so like an SNRI. But it is it's now pretty much just used for ADHD. It's not a controlled substance, so that's good. And it has a very different mechanism of action. So if you've got someone who can't tolerate methylphenidate or the amphetamines, or you have a drug diversion problem, this would be the drug to go to. So an alternative for kids above 6, it's oral. Efficacy better in the morning than the evening. This one has to be given every day. So with the amphetamines and the methylphenidate, if you get to a point where a child is fairly stable and it's safe to do so, sometimes they will do drug holidays. Or they're having side effects, or they're not growing, they will take them off. This is not a drug that you would do that with. So we don't do drug holidays with Strattera. Can be abruptly discontinued. So that's good. The others, we'll talk about the others, have to be tapered. It is metabolized by the 2D6 enzyme pathway. So other drugs that are similar to it, like paroxetine or fluoxetine, which could be used for depression with these drugs, then that would be an inhibitor of its metabolism. Okay, next page, page 11. So adverse effects a little bit different than what we see with the amphetamines. Weight loss, still a problem. But we saw that with some of the SSRIs and SRNIs, that weight loss. Some were weight gain, some were weight loss. Depends on what part of the brain that you're affecting. GI tends to be more of the problem here. And CNS. So it is stimulatory on the cardiovascular. You're affecting norepinephrine, so it can increase blood pressure and heart rate. The priapism is rare, so if you've had problems with that on one of the stimulants, you could use this. Look at the black box warning though. This is suicidal thinking. So there's an increased risk in children who use these agents. So they need to be observed for behaviors that are looked for that indicate clinical worsening. So remember we talked about that depression, kids who have depression, that this was a common comorbid disease, so it certainly is possible that that would happen. Remember that we also saw that with some of the antidepressants, that they could increase suicidal thinking. So you might bring back some of that thinking with this drug as well. Liver is more of a problem. Most of the kids are not going to have underlying liver disease, but it seems to be independent from that as well. So warning them about symptoms that would make you think they had an acute liver hepatic injury would be important as well. So what are the contraindications? Well, we don't want to use them with monoamine oxidase inhibitors. History of pheochromocytoma, that is so rare, it probably wouldn't come on your radar. But severe cardiovascular disease, so blood pressure, heart rate. So you can see diastolic blood pressure increase of 15 millimeters or systolic of 20. So these drugs are very powerful because you're dealing with catecholamines and increase in heart rate. Okay. So that's one of your big go-tos if a stimulant is not useful. So then the last two are the alpha-2 adrenergic agonists, clonidine and guanfacine. So these agents, they're really interesting because you can use them in a wide variety of problems, like withdrawal symptoms can be treated by clonidine. It works on opioid receptors in the brain. So these drugs have more than one receptor system or neurotransmitter system that they work on. We saw that with a lot of the drugs that when we talked about inside. So it's similar here. So if you've got kids that can't use stimulants, didn't have problems with atomoxetine, or they had contraindications, these would be the agents. They are not as effective. But their side effect profile is very different. So we'll walk through these. They also have a delay in response because they're affecting the neurotransmitters in a different manner. On page 12, there is an extended release clonidine that is designed just for use in ADHD, and that is Capvane. Is the name of it. It's an extended release clonidine. So there is clonidine plain, there is clonidine transdermal. These are not interchangeable. So if you want to use clonidine but caffeine, we can't get it covered, it would not. You couldn't substitute one for the other without making adjustments. Let's see. So that's what that third bullet is referring to. Extended release, immediate release clonidine are not interchangeable on a milligram per milligram basis because they have different pharmacokinetic profiles. So clonidine is fairly sedating, so it's a good drug to give at bedtime. And 0.1 milligrams is a very low dose, titrating up to 0.4. So with hypertension, we use up to 2.4, so this is quite at the low end of the spectrum. Duration of action is about 10 to 12 hours. Clonidine, regardless of what you're using it for, requires taper because it will cause a rebound in blood pressure. Not as effective as stimulants, can be used as an adjunct to stimulants. If you're getting partial response but not full response, maybe because of adverse effects or just limited response, you could add clonidine to those agents. Side effects. So think down. That's when I think clonidine, I always think down. So sedation, decrease in alertness, depression, bradycardia, decreases heart rate, headache, possible hypotension. Probably less likely because we use very low doses. So that's clonidine. Then there's extended release guanfacine. So it's called Intuitive. This is this drug works by on norepinephrine, but let's see. Down. I thought it was a depleter, but I think I'm mixing it up with. I'm thinking out loud here for a minute. I'm thinking about guanethidine, sorry. So still an alpha-2 adrenergic agonist. So this one, longer half-life, fewer side effects than clonidine, not interchangeable again with the immediate release guanfacine. So keep it in mind as an alternative. Okay, next page, 13. So because your goal is behavior, you've got to document what is occurring before you start, and then you monitor that. So you're looking at behavior changes. So you would set down, here's what we see: the ability to sit in a chair, the ability to complete a task, the ability to complete homework. It would be those kinds of different types of behaviors. Adult goals: completing a task on time, driving safely, finish one project before starting another. Patient education, while you're using the drug, of course. The side effects are really important because the anorexia, the parents need to know about because they're going to get worried because the kids will stop eating for the most part. So we're going to look at tricks to get them to eat. Not sleeping. Not good when you don't have not sleeping kids because you as an adult usually like to sleep, so it's really hard when your kid doesn't. What do you do with tics if they're experiencing them and warning them about looking at modulations of those over time? The priapism, so all those things need to be discussed. Again, expected length of time. How long is it going to take? Up to 3 months, perhaps. The other is to be realistic in expectations of what this child will look like. Okay? They're not going to be normal, they're going to be different, and we're hoping that we're looking at coping skills, coping behaviors that will make them more likely to be academically successful, socially acceptable, hold a job and be able to earn a living. Okay? So the other is looking at frequency of follow-up, because it'll take some time in the beginning to do that. So if parents are working and they've got to get their kid out of school, then that may have impact on already an academic problems that are in front of them. And behaviors that families should monitor or report. So looking at that substance abuse for kids that are older, and then stimulant diversion or drug diversion in kids probably middle school and up. Okay, so dose titration, maintenance, and termination, just like we talked about the other. So in terms of starting, we're usually going to start with short-acting. We're going to be looking for drugs that will control those behaviors with minimal side effects. A little caveat there, usually good to start on a Friday so that the side effects or the family can start to get used to how that's going to affect them, and they can observe it. You start on a Monday, then it's the teacher observing it. So starting it on a longer weekend or over a holiday may be the best time to do it. Children should not be allowed to administer their own medication. But you will be surprised at how many parents will turn it over. I was just shocked when I was dealing mostly with kids in asthma. In fact, that's all I saw. I never saw adults, but I saw a lot of kids with asthma. And I was amazed at how many parents, I would say, how are they taking their meds? And the parent would turn to the kid and go, how are you taking your meds? Or they'd say, I don't know, ask them. And I'm looking at a 7-year-old. So somebody needs to help. Now, at adolescence, there's always a gradual moving towards independence and handling things yourself. So adolescence, again, but there should be controls in place. How do you monitor and make sure that they're taking their medicine, but also not selling? So the optimal regimen is determined by those core symptoms. What were the core symptoms? The core big areas. Hyperactivity, impulsivity,
and distractibility.
Right, very good. Okay. Let's see. So here, the meal compositions can be associated with decrease in the absorption of drugs. So high-fat meals here can cause a problem, whereas with other drugs like Rispeg, we've seen that we would like to get better. Next page, appetite suppression. Sometimes appetite suppression early on is an indicator that the drug is working. But we usually don't want to keep them that way forever. Okay, so monitoring response. So you're going to monitor those core symptoms and adverse effects. You want parent and teacher feedback at least once a month. You're going to be looking at their height, their weight, heart rate, blood pressure. Teacher feedback, so some way designed that you can get that. I can't imagine that teachers would not cooperate with that and help. Managing the stimulant adverse effects. So the decreased appetite is a problem. Usually the lunchtime is the worst time, and they're not in your view. So some things that they suggest is choose foods that the kid really likes, that they really have a hard time, leaving alone. As their lunch. So, if it's a ding dong or a Twinkie or I don't know, what's y'all's favorite junk food? What are y'all? Reese's. Cheez-Its. What? Reese's. Michelle McNamara, what's your favorite junk food? After you, that's what I know. She's the runner. So after you run, do you ever treat yourself?
I kind of crave healthy food after I run.
Oh.
It's not like the worst kind of runner.
I'll give you a list.
Okay. Brian, what's your favorite junk food?
Berries, probably.
I love
Ice cream. Okay, I'm there. Shannon, what's the favorite junk food in your household? What? Really? Yes. Not sweet, just goldfish. You like the pizza flavored ones, or just the regular?
I like goldfish.
Ice cream.
I have the cheddar bunny.
ice cream.
They're still okay.
Okay. So the other is nutrient-dense food. You've heard that term before. So apple. Yes, there we go. Apple. So if we could get nutrient-dense food that they really like to eat. Maybe you'll have a little Michelle that likes apples, or a Ryan that likes berries, and that's what you would hopefully get them to eat. Okay. Poor growth on the next page. So this is where the drug holidays can come in for kids. And there you see it's the drops the growth trajectory in 2 major percentiles. So they haven't done, so you're in peds, you haven't done growth curves yet? So the other would be is to see a dietitian. If you really are struggling with it, maybe their behavior and performance is doing well, but from the standpoint, maybe you've got a little skinny kid to start with, and there's real concern, or the parents are really concerned about weight loss, then visit with a dietitian. Blood pressure. Adequate fluid intake usually can help that a great deal. Salt intake as well. The other is to look at peak effects. So when the drug peaks, what is the behavior or the side effect they have at that time? And then you can use a different drug that would peak at a different time, or one that would have a lower peak. Mood lability, again, peak is maybe the time where they have the worst attitude or a change in attitude. Or it can be a symptom of wearing off. So 2 different things, when the drug peaks and when the drug wears off. So when the drug wears off, their old symptoms may start re-emerging. And if they had problems that way before, they will come back. So that's the distinction, is that when we're dealing with an adverse effect, or we're dealing with it, the drug just doesn't last long enough. Rebound is the wearing off. So it's the return of symptoms, and so those are going to be what the parents are going to see at night, usually. And so that's when maybe a short acting can help at the end of the day. Tics there's nothing there I'm going to add to. Psychotic symptoms. So you stimulate the brain enough, sometimes it'll hallucinate. So that will require either different drug or different dose. Diversion and misuse at the top of page 16. What?
I'm just checking to see.
You just trying to pick up some good tips?
I'm assessing the quality of the instruction.
I've been here more often than you are, so I can tell all kinds of stories about it. Okay. Diversion and misuse. Monitor symptoms. The pharmacy is going to be monitoring refills. They won't let you have refills earlier if you run out early. Open discussion. I don't think there's anything I haven't already told you. Treatment failure. So lack of the core symptoms becoming better. So you have to look at, are they taking it? Is it enough drug? Is it rebound? So you're using short-acting drugs and the symptoms keep getting worse. They're occurring in the middle of the day. So that's where you look to see if you can use a different drug, or you move to a different class, or you supplement with the class to the amphetamines. At least 1/2 of children who don't respond to one stimulant will respond to another. So we've seen that multiple times. In a class even, sometimes, even though they act the same, the drugs do, that a different drug works better for a different person. Side effects may occur with one type of stimulant, but not another. That's why you need to tell people, and parents, who have been struggling with a child's behavior. And now you're going to go through a period of time, 3+ months, where all this is going to be different. It wears them out. So support and upfront knowing this is what it's probably going to take. People can deal with better than thinking, put them on a pill, they're going to be better. So realistic expectations will be helpful. If they're working with a teacher who's been through this before, that will also be of help. Children don't respond to a second stimulant, then moving to the non-stimulants. Always looking at lack of adherence. Number one, if you do not walk out of here thinking that all the time, most of the time people do not take the drugs the way you prescribe them. Diversion, realistic expectations, and also think, could there be something else going on? If anxiety or depression is a separate comorbid disease, maybe that is what is causing the problem, so not ruling out other causes. Next page, the maintenance. So hopefully you can get into maintenance fairly soon. It is regular monitoring along the way. Adherence also tends to wane. Remember the story I told you about driving a car? Everybody gets worse as the longer they drive. So same thing with taking medication. Some people don't like to take medication. They don't like the way it makes them feel. They feel different. They're not the same person. So as soon as they feel better, and they will move back sometimes to a different, to want to be in a different place or a different stage. Work holidays, I think I've talked about all of those. Termination. So when can you ever stop? Yes, you can stop at some point. It should be individualized for that person. What would it mean? And it should be supervised. So I think giving patients hope, especially older adolescents, giving them hope. Yes, there may be a point where you can come off of this, but let's plan that together. If you ever feel like you're going to take yourself off, call and let's work through that. Remember the drugs that you can't stop, like the clonidine. We don't want to stop that and taper it off. Okay, that's all I know about ADHD. Yes?
So the little girl that I was nanny had really bad ADHD,
Yeah.
and I actually did genetic testing to figure out what drug would be best for her.
You know, I put that in here, but I just didn't have any time to look at it. So.